Today we're going to talk about cellular regulation and immune function. So let's start off with defining cellular regulation. Cellular regulation is the function carried out within cells to maintain homeostasis or balance in the body. It does so in the body through two processes called cellular replication and cellular growth. It's really important for us as nurses to understand cellular regulation because in clinical settings, it gives us the ability to evaluate our patients' ability to transport oxygen and carbon dioxide. It helps our patient to maintain intravascular volume, coagulate blood, and combat infections. And it does so through the process of cellular replication and cellular growth. So what is cellular replication? Cellular replication is better known to us as a cell cycle. In other words, it's a series of events that take place in a cell as it grows and divides. You can also think of it as the life cycle of a cell. For most cells, this takes around 24 hours to complete, to go from birth to fully developing. Human cellular growth has a few qualities. It has to be regular, it has to be functional, and it has to be differentiated. When we have any deviations from these qualities, that's when we start to see issues. For example, cancer can be an issue with cellular regulation because the cell becomes not functional. A lung cell in a pancreas is not a functional cell. It can't do the job of the lung cell in a different area of the body. So it's a deviation from that cell cycle and cellular replication. HIV is also an issue with cellular replication. Think about how HIV divides in the body. It interferes with the RNA inside the cell. So that growth is not differentiated. In other words, the cells of a virus should not be in a normal cell. So I cannot see that they kind of merge together. So they lose that differentiation. In either situation, the results are cells are not supposed to replicate. Abnormal cells are not supposed to replicate. And when they do, they cause problems in the body. So let's talk about cellular growth. Cellular growth occurs through a process called hematopoiesis. And everything this hematopoiesis begins in the bone marrow. When we look at how that occurs, we know it occurs inside the red marrow of the bone. And it is stimulated by something called hypoxia or low oxygenation. Will stimulate the production of cells. In the bone marrow is where everything starts to happen. Okay, the very infancy of cells within the marrow are something called stem cells. And these stem cells are cells that occur in the body, and they can be anything it wants to be when it grows up. Some of these stem cells grow up to be red blood cells. Some of them grow up to be white blood cells. Some of them might grow up to be platelets. Okay? But they have to be produced through a process called hematopoiesis in order to grow. So let's talk a little bit about one of the functions of cells. Cells are something that make up blood and blood products. And when we look at blood, we have to start thinking of blood as a fluid. When we look at blood as a fluid, we can understand a little bit more about how we treat a person when they are low on these cells or low on fluid. Our body has about 5 to 6 quarts of blood in the average of adult. So you can see if somebody is low on blood, then we might notice that they are low on fluid, right? So as we go through things today, remember that blood is viewed as a fluid, and sometimes some of that treatment is replacing that fluid. So as we look at the different portions of blood in the component called formed cells, we're going to focus on 3 of the formed cells today for our discussion. So the first thing that we're going to look at are neutrophils. Neutrophils are also known as white blood cells, and their primary job is to combat infection. Thrombocytes are platelets. Their primary job is to clot blood or help with the clotting process. And then we have erythrocytes or red blood cells. Their primary job is to transport oxygen and carry carbon dioxide away in a molecule called heme. This makes up the component of hemoglobin when we look at blood counts. So let's talk a little bit more about erythrocytes. Erythrocytes, remember, are red blood cells, and these red blood cells reproduce through a process called erythropoiesis. Erythro, if you remember, is erythrocyte, that's red cells, and the poiesis is that formation. We looked at that back a couple of slides in the term hematopoiesis, which is the production of stem cells. This is the particular production of red blood cells. And the trigger for erythropoiesis is oxygen level decline. The oxygen tissue levels are what regulates this process. So when we have a decline in O2, as you see across on the other side of the slide, we have a trigger for the body to say we need to produce more red blood cells because their job is oxygen exchange. They help with carrying oxygen to the lungs and excreting carbon dioxide. When we have a decline in erythrocytes, it is called anemia, and we're going to talk a little bit more about that in a few slides. So let's talk a little bit about the life cycle of an erythrocyte. The erythrocyte, as we know, starts in the bone marrow. The bone marrow then, when the body experiences hypoxia, the bone marrow then produces these stem cells that turn into red blood cells. Okay, the kidneys also help by releasing erythropoietin to help form the red blood cells. The life cycle of a red blood cell is around 120 days, and the storage and removal of these red blood cells occurs in the spleen. So that's important to understand, because if we have someone with splenic dysfunction, they are at risk for anemia or erythrocyte problems. We can also have erythrocyte problems or erythrocyte production problems through hemolysis or destruction of red blood cells. We can see that in our patients who become anemic, like maybe they've fallen and they've been down for a few days and their body goes into an acidotic state. That hemolysis occurs. We can also see it in hemorrhage or blood loss, where we would have a deficiency of these red blood cells. When we look at the leukocytes, leukocytes are also known as neutrophils, is the type of leukocyte or red white blood cell that we talk most about. The neutrophil is involved in early inflammation process and phagocytosis to fight a infection. Neutrophils are an important thing that we're going to look at in the complete blood count, and we're going to look at something called the absolute neutrophil. When we look at neutrophils, we think about mature versus immature white blood cells, and the mature white blood cells are able to fight off infection. The immature white blood cells, those are kind of like those stem cells that are turning into white blood cells and growing up as they grow up in the phase of production of the white blood cells. And we have to have a balance of those. We have to have mature white blood cells and immature white blood cells in order for someone to have an immune response. If we have too many immature cells, then the body isn't able to fight infection because those baby cells or those baby bands don't know what to do. So it's important to look at leukocytes because they help us fight infections. And when we look at the neutrophil count, it helps us to see how our patients are fighting that, if they have enough mature cells in the body for that, fighting infection. Platelets, on the other hand, are that cell that helps us in the clotting factor. Platelets produce a little plug over the openings in that capillary wall, and they help to shrink clots and retract those as the body heals. If we have somebody that is low on platelets, they have a bleeding risk. That platelet plug cannot form, and they are predisposed to things like petechiae, bruising, and bleeding. So how do we assess cellular regulation in our patients? How do we know that a patient is able to complete those functions of the body cells growing and the body cells replicating? One of the important things that we're going to do first is take a health history. When they take a health history, we want to ask things about history of anemia or platelet problems, or a health history of personal or family on fighting off infections. We also want to monitor vital signs. Sometimes with anemias, we can see the heart rate or tachycardia in a patient with anemia. We could also see a low blood pressure. Remember, there's a fluid loss, so low blood pressures could be part of a cellular regulation issue. We could also want to monitor temperature when we're looking at vital signs. When we have somebody that's at risk for infection on those 3 cells that we're concerned about, we could have a fever, or we could have hypothermia, where they are not regulating their body temperature at all. And then, of course, oxygen saturation and respiratory rate is important as well. Remember, our red blood cells are a function to carry oxygen. And so if a patient is not oxygenating well, they may increase their respiratory rate or decrease their oxygen saturation or have changes there. And so vital signs give us an important clue as to what might be going on and how the cells may be responding to the issue. We also want to ask questions on our physical exam. When we look at physical exam, we want to look at things like the skin, the hair, the mucous membrane color, temperature of the skin. What does their skin turgor look like? How about their skin integrity? Do we see any changes in their skin that might be concerning for anemia or bruising or infection? How about their mucous membranes? What color are they? Are they pink, where it looks like they're getting good, healthy, oxygenated blood flow? Or are they pale, where it might mean that they're getting blood flow, but maybe the blood does not have the oxygenation-rich component that is needed, so those membranes maybe look pale? Or what do they look like? Do they have sores on them, or something that would be concerning that maybe the white cells aren't functioning and things are not intact? We're also going to look at, ask our patient in their physical exam about shortness of breath and listen to heart and lung sounds. Shortness of breath can be a sign of anemia. If your body cannot carry oxygen, then you're going to be short of breath with activity. We're going to also listen to heart sounds or lung sounds, because with hypovolemia, because remember blood is a fluid, we can see changes in heart sounds that tell us as the healthcare provider that maybe the patient is a little low on fluid or maybe retaining some fluid in which we do not want them to do. Diagnostic imaging and labs are also a way that we can assess cellular regulation. When we look at diagnostic imaging, we can look at things like CAT scans or x-rays to determine if there is a bleed or a mass that may be causing some of these cellular changes. Labs, we're going to be primarily concerned about either a bone marrow biopsy to look at what's going on hematologically, or more simply, a complete blood count. And that's going to help us to screen for any anemic abnormalities and monitor with treatment. And our bone marrow biopsy is going to help us to diagnose issues. One of the diagnostic tests that we can use to assess cellular regulation is the complete blood count, or the CBC. The areas in which we want to pay attention to are the white count. Remember, those assess those leukocytes or neutrophils. The RBCs, which assess those erythrocytes or red blood cells. And there's a platelet count that assesses those thrombocytes. Okay. When we look at the other portions of this CBC, we have something called a hemoglobin and hematocrit. The hemoglobin assesses the body's ability to carry oxygen or heme around the body, and correlates directly with the red blood cells. So sometimes we might see somebody who has a low red blood cell count and they have a low hemoglobin and hematocrit, and we may treat that person with blood transfusion to bring both of those back into normal range. When we look down at the other letters, the MCV, MCH, MCHC, RDW, those four acronyms have to do with the cell size. And if we are concerned about anemias or issues with erythrocytes, our cell size will give us some indication of the type of anemia that we might be having, and help us to get a better idea how to best treat this anemia. When we look at the white count, we can look at what's called a differential. And the differential that we're concerned about with a white count is the neutrophil percentage, or the absolute neutrophil count. Again, this will tell us how many mature versus immature white cells that we have ready to fight infection in our body. So just to summarize again, with the CBC, we're interested in the white cell count, the red cell count, the platelets. Okay, that's what we look at first. Are they within normal limits? If they're not, then we can start looking at the differentials and figure out why. So the RBC, that's the erythrocytes. I'm going to be concerned with hemoglobin, hematocrit, and those cell sizes. That's going to give me an indication as to why is my red count low. With the white count, I'm going to look at the normal range, and then I'm going to go look at the differential and determine, do I have mature versus immature white cell counts. So the CBC is really used as a screening to identify cellular regulation issues. Now, as we know with screenings, they are just a tool to identify a problem, and they do not diagnose a problem. If we need to diagnose a problem, then we're going to move on to the bone marrow biopsy. Okay, in some cases, the bone marrow biopsy looks at the cell cycle from the beginning to the end. So if I have a lot of irregularities, or I am concerned that I might have some type of issue on a cellular level, I can do a bone marrow biopsy to diagnose an issue. And the bone marrow biopsy is done under sterile technique. They insert a bone marrow biopsy needle, through the bone into the marrow. So the most common site is the crest of the pelvis, as you can see here in your picture. And they aspirate the marrow out of the bone itself, and then they can run a test on it, look at it under the microscope, and analyze it for abnormal changes. This is something that nurses can help assist a physician with. Patients will need to be either in a prone or side-lying position, and they need to remain still. The doctor will use some anesthetic so that the needle going through the skin is not painful for the patient. And then once the needle is inserted into the bone, the patient will feel pressure, but they must stay still until that aspiration occurs. And then afterwards, we want, as nurses, to monitor for any bleeding at the site, any concern at the site. Bleeding and infection are the two complications that can happen with a bone marrow biopsy. And we just want to make sure that we are assessing for those. So patients may be asked not to take blood thinners or aspirin prior to a bone marrow biopsy. And then we're going to monitor that site for bleeding and infection afterwards. So when we've talked about cellular regulation and how it can be normal, right? We talked about cellular replication and cellular growth and how it has to, what it looks like in the normal person, right? We've talked about how to assess for cellular regulation and assess that the functions of those cells, oxygen transportation, infection control, and bleeding are assessed in a patient, and how we monitor those if we're concerned about any issues. But what happens when cellular regulation is impaired? What do we see in our patient when cellular regulation is not working well? Well, when we have an issue with red blood cells or the erythrocytes, we can typically see anemia, which is not enough red blood cells, or polycythemia, where there's too many red blood cells. For our leukocytes or our white blood cells, we see leukopenia, okay, or neutropenia. It just depends on the literature that you read, where there's not enough, and leukocytosis, where there is an excess, okay? So for leukopenia, they are neutropenic or immunodeficient. For leukocytosis, there may be an infection that's going on, or it may be a false elevation due to producing too many immature white blood cells. Thrombocytes or thrombocytopenia, excuse the typo there, thrombocytopenia is not enough platelets. Thrombocytosis are too many platelets. And you can think about the function of each cell: oxygen transportation, infection control, and bleeding, and what a patient might be at risk for if they had not enough. So that's your EMIA or ENIA, not enough, or too many. The cythemia or cytosis can be the term that says that there is too many. So why does this happen? Why does our cellular regulation become impaired? Well, you can see on the screen that when we have cellular regulation impaired, you can see your normal blood here. And within the normal blood, there's a nice little balance of white cells, red cells, platelets. But as we make less in anemia, you can see that the slide looks different. We've gone from about 10 or 20 cells in this slide to only about 7 or 8 in this slide. That is evidence of anemia. Where we have polycythemia, we have that overproduction. So you can see we've almost doubled the amount of cells that we can see in a smear. And then we have some other things that have to do with genetics called sickle cell anemia. We're not going to talk about that in this class. I'm just mentioning right now that typically the first three are physiologic processes. The last one, sickle cell anemia, is due to a genetic predisposition that you'll talk a little bit more about in your pediatrics courses. We can also see issues with anemia, so changes in how many cells we have in our body due to nutritional deficits. So with anemia, we have different forms of anemia that can occur because we're not taking in enough nutrients in our diet, such as iron or folic acid or vitamin B12. We can have an issue from a dietary standpoint or a physiologic issue with absorption. So where we may not be making enough intrinsic factor in our body to absorb the nutrients that are beneficial to our body from the food that we eat. And anemia has also occurred due to fluid loss, right? You can see here, this is not an excessive amount of fluid loss in this hand, but you could see if it was surgical or something along those lines, or we had damage to the marrow itself and lost the function or lost the ability, lost the fluid in the body, that we might experience anemia as a result of this. So what do we expect to find in our patient with impaired cellular regulation? We have, so on a normal patient with cellular regulation, right, we talked about having pink mucous membranes. We talked about them having vital signs within normal limits. Think about that normal patient assessment. Think about the functions of those cells. And let's talk a little bit about some of the things that we would see on a patient without this function. We're going to see fatigue, pallor, shortness of breath, right? Fatigue because we may be fighting an infection. We may be having the inability or activity intolerance due to the poor oxygen carrying capability that we have. We have patients that are pale because oxygen-rich blood is red, isn't it? Very beefy red, very healthy looking. If I don't have cells, enough cells, it's going to take away that color and wash that patient out. So they're going to have pale skin or maybe pale mucous membranes. And then short of breath because they cannot tolerate activity because the oxygen need is higher than what their body is producing. Tachycardia can be something that's seen in our patients because that is a compensatory mechanism. As the heart speeds up, it's trying to make more oxygen, move more cells around the body to get them to the lungs to become rich in oxygen. We may also see stomatitis or sores in the mouth. Now, this typically can come from the skin impairment that can happen with patients who have impaired cellular regulation. We can also have, with these next three, stomatitis, inflamed and cracked lips, or painful swallowing. This is because the GI tract is very sensitive to changes in cellular regulation. And depending on what might be going on, there could be changes as a result of that, where that skin integrity is not as good as it once was because of the changes in cellular regulation. We have tachycardia listed twice there. That's a little bit of an error on my part. Okay, so as you look at those items on the previous slide, please think about what is going on in the body and as it relates to cellular function and how a patient may be showing us that they're not feeling well. So why does a person have cellular regulation impairment? The first reason is aging. As we get older, we have more risks for things like anemias or things like infection control. So as age occurs, we have a risk for cellular impairment. We also have a risk for cellular impairment with poor nutrition. So iron, B12, folic acid are three things that we want to make sure that we have in our diet to help with cellular regulation. And as people get older, there are some things that they're unable to eat. As they get older and they experience changes in income or experience changes in the ability to cook for themselves. So they go from cooking for one person or cooking from two people to cooking to one person. And then they go on a limited income. Those sources of nutrition and sources of things are less than what they were before. So their diet changes, and they're not able to get the dietary sources that are needed for cellular regulation. So poor nutrition can be a contributing factor. You can also have a contributing factor with environmental exposure. Someone that has had a history of radiation for cancer, someone who smokes, or environmental pollution can cause changes in the cellular cycle and cause some changes with cellular impairment. Medications can also induce impairment with cellular regulation. So those medications that might decrease white cell, red cell, or platelet production, we have to watch for and screen for those patients. Proton pump inhibitors or medications that patients take for like heartburn to decrease stomach acid, that can decrease absorption of nutrients. Remember, one of the causes that we see with anemia, why it happens, is nutritional absorption. We have medications that can impair that nutritional absorption and therefore cause someone to have anemia. And then we can have genetics play a role in those who are at risk for impairment. Things like sickle cell anemia or something called Polycythemia vera, which is an overproduction of red blood cells. Those are both exemplars of items that impair cellular regulation that have a genetic component to it. Also, things like cancer, impairment in cellular regulation is cancer, and there are genetic ties to that as well. Some diagnostic testing that we can use for assessing an impairment in cellular regulation just is kind of a reiteration of what we talked about previously, but we want to look at the complete blood count, specifically the hemoglobin and hematocrit, the mean corpuscular volume, mean corpuscular hemoglobin. That's the size of the cells and their ability to carry hemoglobin around the body. Right? These that I've listed are very specific to red cell or erythrocyte types of deficiencies. We also want to look at the platelet count, right? We want to assess our deficiency in platelets to assess for any platelet problems. And then I should have put on there white blood cell assessment. If we have an impairment in cellular regulation, we want to look at the total white count and the absolute neutrophil count, okay? Then if we see issues within a different cellular level, so let's say we're up here looking at somebody's complete blood count and we have an issue with the red cells, okay? Then we're going to determine what might be going on from a nutritional standpoint. And that's where these next labs come in, right? Remember those risks? We said poor nutrition was a risk. So one of the assessment tools that we can use to assess risk is a ferritin level. A ferritin level is the total amount of iron that's in the body, okay? And then we look at the body's ability of those cells to bind to that iron. So when we're looking at a patient profile, we may see somebody on their CBC that has a red blood cell count that's low, and maybe their hemoglobin is low, okay? Their cell sizes look okay, but they have a low hemoglobin and low red count. And they share with us that, they really don't like red meat and they're an older elderly person, okay, I've got to look at why. So I've identified anemia. I've identified risk factors. I might order a ferritin level or a total iron binding level to determine if this is an iron deficient anemia. I might also draw a B12 level to determine if this is B12 or pernicious anemia. Okay, this just gives us more information on nutritional risk factors, since we know that's a risk factor for cellular regulation. All of these are help us to understand what might be going on. If we're still not getting answers and we're concerned with maybe the size of the cells, or we have some abnormality in all three areas, the red cells, the platelets, the white cells, we may look at a bone marrow biopsy to determine and diagnose any type of cancers or any type of aplastic anemia on a deeper cellular level. Remember, bone marrow biopsy is diagnostic. It diagnoses an issue, but the complete blood count, it screens for an issue, and then we get more specific in looking for the cause as to why when we look at differentials and different nutritional elements in our body. So what do we do if we have a patient that has an impairment with cellular regulation? Well, the first thing we can do is replace the deficiency. If we know it's a nutritional deficiency, we're going to talk to them about increasing their diet with sources of iron. Red meats, green leafy vegetables, those types of things will help us increase that in their diet. We can also do nutritional supplements. So a person could take an iron pill to help with anemia. In addition to that, we would add vitamin C to help with absorption there. Okay. If we feel like it's a B12 deficiency, we can talk to them about increasing B12 sources in their diet, and then maybe adding some sort of a B12 replacement. Okay. So the first thing we want to do is replace the deficiency, either through diets, medications, or a blood transfusion. Okay. When we are giving a blood transfusion, we could give just platelets if that's what we needed, or we could give packed red blood cells. For giving packed red blood cells, that is something that is a high-risk procedure, so we have a lot of checks and balances that we will do through there to make sure we have the right patient and the right blood type, and we only give blood transfusions with normal saline to allow for that fluid replacement to occur. We also can sustain the reproduction of cells when we're managing cellular impairment, right? When we talked about how cells are produced and how we have anemias, one of the reasons is like blood loss or issues with a production of those cells, right? It can't replicate, okay, or they can't grow, okay? So we can give a patient growth factors. We can give them a product called Neupogen, or filgrastim, or we can give them a product called Epogen. Okay, Neupogen stimulates the growth of white cells. Epogen stimulates the growth of red cells. And so we could give them this product and help them make more cells if need be. We also may need to look at stopping the excess. If we have an overproduction of cells, and that's our issue with cellular impairment, we can stop that excess production through therapeutic phlebotomy, where we take blood away from the body, and we can do that with polycythemia. We could use chemotherapy to kill the cells. Remember, chemotherapy is a format in which medication in which they're cell specific or cell non-specific, and they can destroy some cells or they can destroy all cells. So it would help with an overproduction of cells. In something like cancer or leukemia, we could use chemotherapy to stop the excess production of cells. And then we could use antibiotics, right? If we have an overproduction of white cells due to an infection, we can use antibiotics to treat that infection and help the white cells to go back to normal. And then the last thing we need to do in managing the impairments in cellular regulation is make sure that we're addressing any safety needs that our patients have. When we have concerns with cellular regulation and we have issues with oxygenation or low volume, we have safety issues that come up. Our patients become at risk for falls because they may be dizzy when they sit up due to the low blood volume. They may be at risk for falls because of activity intolerance issues. They can't walk down the hallway without having to stop or getting woozy, right? We have different types of anemias. When we look at B12 anemia, it has a lot of neurological presentation with it. And so we may have to help patients whose fingers are numb or they're feeling very tingly and have an impairment in neurological things. That has safety risks that come with them. So we need to be identifying those safety risks and putting a plan in place to keep our patients safe if they're experiencing those. So let's talk about some examples of anemia. And there are 4 types of anemias that you will need to be aware of for this course. The first one that we're going to talk about is iron deficient anemia. When we look at iron, we know iron is a component of hemoglobin, and we must have that healthy hemoglobin to carry oxygen to our body tissues. If we have insufficient iron, we have a decrease of production of the hemoglobin, resulting in a decreased ability of the red blood cells to transport oxygen to the tissues. It also encourages a depletion of individual iron stores, and we could see a disconnect there and an imbalance between dietary absorption and loss of that. We know that iron is stored in the liver, spleen, and bone marrow. So these are 3 important organs that must be functioning in order for a patient to not have iron deficient anemia. Those at highest risk for iron deficient anemia are infants, children, and pregnant women, and elderly. So think about nutritional intake, right? Infants are at risk because their body does not produce as many red blood cells as they are growing. And by about 9 months of age, they've already used all their red blood cells that they were born with at birth. So we could see an iron deficiency as their body is starting to do things on its own. Children and pregnant children and elderly tend to have iron deficient anemia due to nutritional intake and changes with absorption. And pregnant women tend to have iron deficient anemia because they are producing red blood cells for 2. So pregnant women tend to give baby all their iron, and then they themselves are deficient in that as baby is growing. When we look at iron deficiency anemia, remember our assessment findings for anemia are the same. We've already gone over some of those assessment findings. Our patients are going to be tired. They are going to have some shortness of breath. They're going to have some fatigue, right? When we look at the diagnostics, their red cells are going to be low. Their hemoglobin is going to be low with iron deficient anemia. And then the ferritin and total iron binding levels are going to be low, indicating a deficiency. So what do we do when our patients need treatment for iron deficient anemia? We can supplement in our diet. We could supplement with medication. Remember, we're going to fix that deficiency with diet and medication. So you will need to know some good sources of iron. If you're educating your patient, what are some good sources of iron for them in their body, and how can you help them to include more of those? We have things like iron-fortified cereal, iron-fortified orange juice, as well as red meats and leafy green vegetables. We also can supplement iron deficiency with an iron pill If they take an iron pill, they're also going to need to take it with vitamin C. And we also want to make sure that they have a stool softener as part of their prescriptive items, because both can cause constipation. The vitamin C helps with the absorption of the iron, and the stool softener helps with the excretion. The other thing, if the oral supplements do not work, we can give iron intramuscularly. If we have to give iron intramuscularly, we have to use the Z-Track because there is a lot of staining that can be involved, and absorption is important. We can also give iron IV. If we give iron intravenously, it has a very high risk of anaphylaxis, so it has to be, we do a test dose first, and then if the patient does well with the test dose, we can continue the infusion. But we want to make sure that we're assessing that IV site and making sure that it is safe for our patients to continue to receive that. Moving on to B12 anemia. B12 anemia is something that it usually occurs from your body being unable to absorb B12 in your diet. And it can either be from not taking enough B12 in the body. So vegetarian, if you follow a vegetarian or a vegan diet, you have a higher risk for developing B12 anemia because you're not taking in those B12 rich sources like meats and those carnivorous meat sources. But we can also have B12 deficiencies with individuals who have chronic alcoholism or take or have Crohn's disease or take proton pump inhibitors because their gastric intestinal tract loses the ability to absorb nutrients. And if that happens, sometimes we use that term as pernicious anemia to differentiate it from a dietary anemia. So the symptoms with a patient with B12 anemia can be different than a red blood cell anemia. And this is because demyelination can occur with pernicious or B12 anemia. And with the demyelination, we can see a lot of altered mental status or visual disturbances that come about as symptoms in our assessment. And if you see those neurological differences, in addition to the signs of anemia, we can be looking at a B12 deficiency. B12 deficiency is a slow progression, and the clinical manifestations are delayed. So our CBC is really important here because it might be the first time that we see a problem, right? If we want to look further, which we will, okay, we'll have a low red blood cell count. We'll be scratching our head. That's not right, okay? We're going to look a little further with a differential, okay, to check out the cell size, okay, and we might add a B12 lab draw to determine if that is where the deficiency is at, okay? Our B12 level tells us if it is a B12 anemia. We can also draw something called intrinsic factor levels, and this helps us to differentiate B12 anemia from pernicious anemia. The intrinsic factor is low. That means that there's probably some absorption issues in the gastrointestinal tract, and we're looking at a pernicious anemia. So we want to treat B12 anemia with, again, how do we treat a deficiency? Go back to the previous slide. We can put a deficiency treatment in our diet. We can put it in our medication, right? So talking with patients about absorption, okay? But, not absorption, but intake. But if they have an absorption issue, right, we may have to look at giving them the B12 a different way, and that would be in the form of medication. Typically, B12 is given in injections, subcutaneous injections, because remember, it's an absorption issue. So if I give a pill and the pill goes through my GI tract, it's not going to do any good because my GI tract can't take that B12, right? So I give subcutaneous injections because I still get the medicine, but it goes a different route in my body. Aplastic anemia is the next concern. Aplastic anemia is a dysfunction of the bone marrow, and so this particular diagnosis is very serious. Aplastic, the A in front of plastic, means the bone marrow is ceasing to function. It is not producing the stem cells, therefore those stem cells are not turning into red cells, white cells, or platelets. So I'm seeing changes in my red cells, my white cells, and my platelets on my CBC. This is a very life-threatening anemia because the body can't produce cells at all. It can't fight infection, it can't carry oxygen, it can't stop bleeding, and those functions are essential to life. If somebody has aplastic anemia, this can be something that is caused by a lot of those environmental exposures. Typically, someone with radiation exposure, chemotherapy exposure is at high risk for aplastic anemia. If they've had a history of cancer treatments, they're at risk for aplastic anemia. This is diagnosed on a bone marrow biopsy, and we treat symptomatically. Okay, and we can also treat with a bone marrow transplant, right? We want a reset of that bone marrow to hopefully take out the old bone marrow with chemotherapy, put in the new bone marrow, and hopefully reset the cellular reproductive function in the body. Thrombocytopenia is the last disorder that we want to talk about today. And thrombocytopenia is a decrease in platelet count. And so these patients are at risk for bruising, at risk for bleeding, okay? So their abnormality on their CBC is going to be that low platelet count. When we do our physical examination, we're going to see bruising. We're going to see evidences of bruising and maybe petechiae, which are like little purple dots all over the body, okay? We may have them come in and tell us that their gums bleed excessively after brushing their teeth, or maybe they're experiencing a nosebleed. We would be able to look at that CBC and determine if it is the platelets that are indeed concerning. Okay, but when a patient is at risk for bleeding, remember we have to address safety as part of our clinical management. With thrombocytopenia, we have to be extremely cautious with any type of needles, any type of trauma that we might cause to this patient. So there's going to be some precautions called bleeding precautions that we have to put in place to help address safety needs for this patient. I think it'd be a great thing for you guys to do to get into your reading and focus on these 4 different types of anemias, okay? As you're doing that, look at all the things we've talked about that all of these have in common, right? Get into the information and work on maybe some concept mapping or some notes that include some of the things that we've talked about today. And of course, reach out if you have any questions on the different types of anemias that we're going to cover in class. So when we're taking care of a patient with cellular regulation issues, what are some of the problems that we have to be aware of as nurses to make sure that we are addressing in our patients or recognizing in our patients? The first client problem that we can see is an impaired breathing pattern, right? Remember, one of the functions of the cells that we're talking about is carrying oxygen tissues. So if I'm not making enough oxygen and I'm not carrying those to the tissues, then I have an impaired breathing pattern, right? My breathing pattern changes. I cannot tolerate activity as I had hoped before because I cannot carry the oxygen around my body. So what are some nursing interventions that we can do to help our patient with impaired breathing patterns? There's a big blank spot on your slides right next to that picture. What are some things that you as a nurse can help do to help address this impaired breathing problem? Well, we could place oxygen on the patient, right? We could look at replacing that deficit. We might have to allow breaks when we're ambulating with activity, okay? And the list goes on, right? As we're looking as nurses and learning to think as nurses, okay, we have to think what problems could our patients experience, and that changes our nursing care. We can also have a client problem of a fluid volume deficit. Remember, blood is a fluid, so part of the makeup of blood are those formed cells, which are the 3 types of cells that we've been talking about today: red cells, white cells, platelets. So if we have a deficit in any of those cell formations, we're going to replace that deficit, right? So part of managing this client problem might be a blood transfusion or a platelet transfusion, right? We'll also may want to give growth stimulating factors, right? That can help us correct that deficit if my body can produce more. We also have the client problem of impaired nutrition. So how are we going to address the problems of impaired nutrition? Maybe we look at a dietary referral, right? So that they can talk to a dietitian about increasing the sources of folic acid or B12 or iron in their body, right? So, or we look at medication supplementation. How can I take medication supplement to get what my body doesn't absorb or doesn't want to take in? Okay, you will need to be familiar with sources of iron, sources of B12, so that you could talk with your patients about this. And remember, you want to meet your patients where they are. So if you have an elderly patient that has iron deficient anemia but has false teeth, sources of red meat may be unrealistic to look at for sources of iron. Might be hard to chew, might be hard to swallow, it might be expensive. Okay, so what does this dietary plan look like for your patient, and how can you meet their specific needs? We can also have the issue of activity intolerance. If I can't carry oxygen around or I'm low on volume, I'm low on gas, right? So don't have any gas in the tank to do what I need to do for my patient, for my daily activity. So they may sit down more frequently than what they would if they did not have this deficiency. They may wear out quicker. Okay, they may get short of breath walking down the hallway. This may eventually lead to them not being able to meet their personal needs. So we need to be assessing activity intolerance. Activity does not necessarily mean exercise, right? Activity can also mean self-care. So if I have an elderly patient coming into my office who looks very disheveled, right? I want to ask, why are you not able to participate in that normal activity that you would do? Why aren't you able to brush your hair? Why aren't you able to shower? Why aren't you able to complete those activities, right? Maybe they're tired. Maybe they wear out in the middle of a shower, right? Those are things that need to be addressed as activity intolerance. And it is a common problem. Maybe they take lots of extra naps during the day. We need to be asking why that is, because it may give us some insight to what's going on, and we can help our patients manage these problems to restore health. Patients are also at risk for bleeding, right? This is most commonly thought of as an issue with our thrombocytopenia. But when we have a patient at risk for bleeding, we're going to put them on something called bleeding precautions, okay? you can look on this nice little meme here that there are symptoms that we look at for placing somebody on bleeding precautions. We're concerned about blood in their urine, nosebleeds, blood in the gums, or bruising, right? That's our assessment for thrombocytopenia. We want to make sure that we are implementing these bleeding precautions based on our platelet level for this class. If our platelet level is below 150,000, we implement bleeding precautions. Okay. In addition, if someone's on an anticoagulant or if we have some liver disease going, they're going to be on bleeding precautions as well. Part of those bleeding precautions include no aspirin, being selective with our invasive equipment, okay? We do have to do some blood draws, but we want to minimize those blood draws. So we want to decrease needle sticks, and if we have to do a stick, we want to use the smallest gauge needle possible. Okay, so we're doing something with a 22 gauge or less if we are able. Okay, they're also not going to be on any aspirin, and if they need to shave or have grooming, we want them to use an electric razor. Okay, this would be for thrombocytopenia or even maybe in aplastic anemia if we've got a platelet count that's decreasing. And then we have risk for falls, right? If I'm not oxygenating, if I'm low on blood volume, I'm going to be at risk for falls. So what kind of precautions can we take for somebody that is at risk for falls? They wear the yellow socks or socks with grip on them. We want to clean up the environment, right? We're going to want to sit them up on the side of the bed, okay? Give them some time to get their wits about them, and then we're going to just take things slow. We go from sitting to standing. We're going to take that slow, let them get their bearings about them, use assistive devices if need be, gait belt, walker, cane, those types of things. We can use bed alarms if they're at risk for falls. Just want to make sure that we are taking those steps to mitigate risk for falls. Because if we have someone with, let's say, thrombocytopenia that's at risk for falls, we don't want that patient to fall, right? Because that could cause injury and that could cause further bleeding. So it's really important to think about addressing these safety issues with our patients with cellular anemias. So we talked about cellular underproduction, right? And we looked at those 4 different types of anemias. We also have cellular overproduction, and that's in a process called Polycythemia vera. So remember the trigger for hematopoiesis or erythropoiesis, red cell production is hypoxia, right? So sometimes we have some people in a chronic hypoxic state, right? Or they live in an area, such a high altitude area like the mountains, and where there's less oxygen, right? Their body overproduces red blood cells, partly as a compensatory mechanism, okay? And usually if it's due to altitude changes, it's going to stabilize over time, okay? But sometimes we have this genetic predisposition in this condition called polycythemia vera, where our body just overproduces cells due to a genetic deficit there. When that happens, it makes our blood really, really thick when we overproduce red blood cells. There's just too many cells in order for blood to move through the body quickly. So their skin becomes very red. It becomes very swollen. They have a higher risk of clotting. And so a body can't live in a state with those risks for very long because the blood, it can't circulate because it's really thick. So in this situation, we typically have to use a therapeutic phlebotomy or sometimes medication that decreases the production of red blood cells. So sometimes we have to do chemotherapy, not very often, or radiation to decrease the production of red blood cells. Most of the time, the first line treatment is trying that therapeutic phlebotomy, where we take off so much blood, it's like a blood draw, and we fill X amount of tubes each time to decrease the fluid volume and decrease the amount of red blood cells until the next time. So what types of client problems do we have with polycythemia vera? Well, definitely impaired tissue perfusion, right? If the blood is thick, it can't perfuse through the body like it should, so we're going to see some skin changes. With impaired tissue perfusion, we have to make sure blood is getting somewhere because there's a risk of necrosis and a risk of clotting. So we want to make sure in our patients we're aware of those issues and managing that. And to help with this impaired tissue perfusion, that's where we do that therapeutic phlebotomy, right? The more blood that we can draw off, the more it opens up the opportunity in that body system for blood to move through like it should. So we're going to be asking our patients questions. Are you having pain? What does your skin look like? Is it real ruddy, like the hand in the middle, or is it real pale? That indicates maybe blood is not getting where it needs to go. And then we can also have an issue with pain with polycythemia vera. If blood is not flowing, it can be very painful for the patient. And so we may have to do some pain management until we can get those vascular changes resolved. All right. So now we're going to move to talking about immunity. So we've talked about cellular function, and we focus a lot on red cells and platelets. Now we're going to switch gears now and talk about the immune system and what the immune system does. The immune system is our main level of fighting infection, and it allows, if immunity is working, it helps the body's ability to resist infection and fight disease. Now, as we know, there's three types of immunity. There's innate immunity, and that is also known as natural or passive immunity, and it's what we're born with. It develops at birth. It's very nonspecific, and it passes from mom to baby. Okay. The second type of immunity that we have is acquired immunity. And acquired immunity is what we call active immunity, and it develops by exposure to antigens, infections, or we can have acquired immunity through the process of vaccination. And then we also have a type of immunity called the inflammatory response with phagocytosis. The inflammatory response is very basic. It tends to be what happens really basic with an injury or an infection, where we have fever, where we have redness, where we have those two things that tell us that an infectious process is going on. Maybe some general feelings of being unwell, maybe a low-grade fever, maybe some redness. That's the inflammatory response, and it's very non-specific, but it is that first-line defense that says, hey, something's going on, and it occurs within the body. We also have, I want to talk a little bit more about acquired immunity, okay? When we talk about acquired immunity, we need to understand that it utilizes cell mediation and humoral mediation, okay? Cell mediation occurs with the T cells, right? The T cells are present at birth. They're created in the thymus, and their job is to help the body fight viruses. We have humoral mediated immunity as well. This occurs in our B cells, and this part of the immunity is created in the bone marrow and is developed over time. We just talked about that several slides back when we talked about hematopoiesis, right? So when we're looking at white cells created in the bone marrow, this is something that's developed over time, okay? And helps to be differentiated over time to identify bacteria, to help with specific immunities that result in antibodies development in our system. This is a great video. I'm going to encourage you to click on it. It's about 3 minutes long, and it's a great TED Talk overview about how the immune system works. I'm going to let you click on that on your own. I'm not going to show it in this PowerPoint slide, but I will. I would like for you to watch that just to get an overview of what our immune system does. So how do we assess immune function in our patient? When we're assessing immune function in our patient, we can look at this case study here. Mrs. Smith has come to the clinic today, and she's concerned because her knee's been hurting. Upon exam, you look at the following. So what do you want to assess to make sure that your patient's immune system is working? So we know it's working because the scar is red, right? We have some swelling that indicates that the immune system is working. That's that immune response, right? But we have this stuff here that we don't like too much. This is drainage, right? So we want to ask, are we seeing drainage? Are you running a fever? Are you having pain, chills, fatigue? What does this look like? Okay? We see these things, which are very good. The redness, the swelling, the fever, that tells us the immune system has been activated to defend whatever is growing in this yellow drainage here. Okay? So what can we do to help our patient? We can help our patient by culturing this drainage, and we want to do so before we administer antibiotics. We can help our patient by reducing the fever. We can help them by monitoring the CBC. Okay, this patient's probably going to have an overproduction, some leukocytosis, right? An overproduction of white blood cells to fight this infection. Okay, and we want to monitor that because if we start treating this, we want that white cell count to go back down, right? We want to assess the redness that we see and make sure that it is not spreading or progression. We can do that by marking this area of redness that we see around the drainage or measuring it with a disposable ruler. We want to address pain, so Tylenol for pain or something stronger. And we want to make sure that we're washing our hands to prevent the spread of infection. So just in this little picture and this little scenario, when we think about Mrs. Smith, we can see that Mrs. Smith's immune function is working just by making sure and asking her about the steps of the immune response that we should see in patients. Okay. So what do we do to assess immune function? How do we gather further data about what's happening in the immune system? We talked about this a little bit earlier. We start with the complete blood count, but we have different focuses. So the first thing we would focus on is the white cell or differential. Is it high? Is it low? Are they mature cells or immature cells? Okay, we look at the complete blood count to get the totals, and then the differentials to figure out where are those totals coming from. Are they mature cells or immature cells? We can also look at things called viral loads that tell us the amount of virus in a body. We're going to talk more specifically about those that go towards HIV and look at that particular virus, but we can look at different types of viruses when we're looking at viral loads. We can also look at antibody testing. Is our body producing the proper antibodies? Okay. And then looking at T cell or B cell counts, those specific immune responders. And we can look at the functions of our immune system when we look at a bone marrow biopsy. So what happens if our immune response fails to work? Well, if our immune response fails to work, we have a condition called immunodeficiency. Immunodeficiency is defined as an abnormal condition of the immune system in which immunity is inadequate and resistance to infection is decreased. And it happens because we lose the function of one or more components of the immune system, right? They're either not producing, maybe there's a problem with the bone marrow, right? And we don't have that humoral immunity. Maybe there's a problem with the T cells and we're not getting that T cell immunity, right? Maybe there's a problem with maturity and we're not producing mature cells. There's a loss of function of one or more of components of the immune system, and therefore the immune system cannot do its job. So what would our patient look like if they did not have an immune system? Well, you can tell on the previous slides, and I clicked through too fast, so you may wish to go back and click through some of these on your own. But we have a persistent low-grade fever, right? And that triggers, the trigger for producing white blood cells is the presence of infection. The presence of infection is indicated by a low-grade fever, and that tells our body, produce more white cells, something's going on. So if they're not effective, I'm going to have that persistent low-grade fever. I'm also going to have a patient that may have a tendency to develop unusual or recurrent infections, a patient that may have infections where people don't usually get infections. It's like, wait, what is this? This is strange. This is a strange bacteria that doesn't grow in a healthy immune system. We may start to see things like that. We see eczema, thrombocytopenia, low neutrophil count, and low T or B cells. These are assessment findings that are telling us that that immune system is not efficient enough to handle the infections that are coming its way. So as a nurse, if we're seeing these symptoms in our patients, one of the things that we want to do is institute something called neutropenic precautions. And neutropenic precautions is a form of infection control that protects your patient from anything that you might carry in or a visitor might carry in. So there's a series of interventions that we do with neutropenic precautions to help prevent carrying bacteria in. They're going to be in a special room that recirculates air and helps to take the germs out of the air. It's a reverse airflow room. Hand hygiene is going to be super important because it's the number one way to prevent the spread of infections. We're going to make sure that we're assessing their temperature. We may also put them on prophylactic antibiotics to prevent infections, prevent those foreign invaders or those weird types of infections that they can get. We can give them growth stimulating factors, right? Because this is a deficiency. So we can help them grow new white blood cells, and we're going to monitor that absolute neutrophil count. Now back a little bit to the neutropenic precautions. We typically institute those if that ANC is below 1,000. And the steps of those neutropenic precautions are hand hygiene before and after patient care. Staff and visitors wear a mask when entering the room, and patients mask when outside of the room. We typically limit fresh flowers and fresh vegetables because of the bacteria that they can possibly carry in. Once that absolute neutrophil count rises above 1,000, we can decrease the frequency of using these neutropenic precautions, but many times patients wish to use them just to protect themselves from anything that they might catch. So the example of immunodeficiency that we're going to talk about today is HIV. And when we look at HIV, we know HIV is also known as the human immunodeficiency virus. HIV is a bloodborne sexually transmitted virus. It's also transmitted by sexual contact as well as blood contact. Because the virus is found in body fluids, such as blood, seminal fluid, vaginal secretions, amniotic fluid, breast milk. If the blood is, I'm sorry, let me go back just a little bit. The virus is transmitted in a variety of body fluids that we've listed. When we look at the pathophysiology of how that has to happen, we know that the HIV has to attach itself or get into the body some way. And typically it gets into the body through blood or body fluids, okay? And it has to enter through a torn membrane. So it could be an open cut. It could be a tear in the vagina or a tear in the anal opening when we're looking at sexual transmission. Or it could be a tear or trauma where, like baby would pass through the vaginal canal and there would be contact there. It could be a needle stick. Okay, there has to be some way where this body fluid that is infected with HIV enters a host cell. Okay, and it has to happen through a tear in the membrane. Once the HIV is in the body, the HIV attaches to the cell and it begins to replicate through a process called reverse transcriptase. So the normal DNA is replaced with the viral DNA, and the virus begins to grow. When the virus grows and replicates in this way, the patient may or may not know they're sick. HIV has something called a window period where the virus may be replicating, but the patient is asymptomatic. During this window period, the virus or the viral load in the body is increasing, but we may not see a response until the T cells, which are the part of immunity that is destroyed with this virus, become lower than the viral load. Okay, so this window period can be very deceiving in that the patient is actually HIV positive, the virus is replicating in the body, they can transmit it to others, but they wouldn't necessarily know they have it because they have very few, if any, signs of the disease. HIV can progress to AIDS, and AIDS is known as the end stage of this infection. So on the previous slide, the previous two slides, on the previous slide, there is a little 1-minute video from the Centers for Disease Control that talks about HIV and the basics of HIV. I want you to take time to watch that video and think about the implications of this to our nursing care. When we talk about patients with HIV, we have to really understand not only how does it work on the body, but what are the implications for our patients. HIV, with its transmission, can carry some important concerns that we need to address with our patients as far as acceptance, compliance with care, and those are some things that we need to think about, and I think are highlighted very well in this video. When we look at our patient that has HIV, what are some symptoms that we might see in our patients that have this? We know HIV is a state of immunocompromise if they have active disease, right? So when a patient is immunocompromised or immunodeficient, what assessment findings do you see? Swollen lymph nodes, fever. Maybe we see a strange rash, right? Maybe they're achy or having chills, right? Maybe they're really tired. Maybe we look in their mouth and we see sores in their mouth that indicate that an infection is occurring. Okay, or maybe we don't see anything at all. Remember, in our window period, we can see asymptomatic. So we have to remember that and consider that as well. as the viral load increases, okay, as the body has more and more HIV virus in it and less T cells, okay, to fight off this virus, we're going to see more symptoms. So what do we do to diagnose HIV? To diagnose HIV, it takes surveillance over time because of the window period, or the time in the body that the virus can replicate without symptoms. So the first thing that we do is something called serologic testing through an ELISA test, okay? And this is what we call an HIV screen. So the ELISA test can be done in offices, clinics, health screening fairs, and it checks for the presence of the HIV antibodies. It takes about 5 minutes to 30 minutes for a result, and if a patient tests positive with the ELISA test, then we refer them to the healthcare provider for follow-up, okay? The follow-up test is a Western blot test, and the Western blot test confirms HIV diagnosis in adults. This is something that we would do if the ELISA test is positive, okay? If the ELISA test is negative, then we're going to ask our patient to come back and retest in a certain time frame, okay? We could have them retest in 2 months and then again in 6 months, or we could have them test every 3 to 6 months. They would work with their provider to determine a testing regimen. And what we're doing with the repeated test is we're trying to catch that virus in that window period, okay? After a series of HIV screens, after so many negative screens, they can be considered HIV negative. But it could be with that window period that we do a series of screens and one of those screens comes back positive in that window. If that happens, then we do the Western blot test to confirm the presence of HIV. Once they have a positive Western blot test and their diagnosis goes to HIV positive, then we start doing viral load testing to test for the presence of the virus and CD4 counts to determine how does that viral load and CD4 count, how do they match up? Do we have a lot of T cells left? Do we have very little T cells left in that CD4 count? Do we have a lot of virus or a little virus in the body? Okay. And the CD4 count and the viral load testing are going to become very important as we start to determine how they're going to respond to therapy. So once we begin antiretroviral therapy, okay, which is started almost immediately after we confirm the diagnosis of HIV, okay, if the retroviral therapy is working, their viral load should decrease and their CD4 count or their T cells should increase, right? Because there's less of the virus that is taking away the T cells in the body. If we have the opposite effect, if they've started retroviral therapy and they're not responding, so the viral count is increasing and the CD4 count continues to decrease, okay, we have a progression of the disease, the first thing we need to ask about is, are they taking their medication appropriately? Usually with antiretroviral therapies, they take 2 to 3 meds from 2 to 3 drug classes, and they have to take them all. If you leave one out or don't take one, then it's not working appropriately, okay? A decreased viral load means a longer time without a longer time where your body is fighting this virus. An increased viral load means that the virus is winning, and it could also mean a decreased survival rate because your body may not recover. So diagnostic testing is a very, very important thing to understand, and we can use it in 2 ways. We can use it to screen, we can use it to diagnose, and we can use it to monitor the response to therapies. So how do we manage HIV in our patients? Antiretroviral therapy is the first start. Antiretroviral therapy targets the HIV virus, and it impairs the replication of the virus if taken correctly. As said previously, patients usually take 2 different medications, and if we need to add medications to that, we can. And we use our viral load to assess the response to therapy. If the viral load's not responding, then a combination of medications can be changed until we get the therapeutic response achieved. But please know that medication is expensive and it must be taken in multiple. So I don't just take one antiretroviral therapy. I usually take 2 or 3. I also manage HIV by decreasing the risk of infection, right? In addition, to take the viral load down, also want to prevent opportunistic infections. And that's why we give that prophylactic antibiotic therapy. Antibiotics can be added to the therapy if the CD4 count declines, and they kind of personalize the antibiotics to what they're most at risk for based on the CD4 count. So they may have different antibiotics at different times depending on what their blood levels are doing. There's also a psychosocial component that we want to make sure that we address with our patients. And many patients with HIV are on antidepressant therapy. They are on antidepressant therapy to kind of help with the diagnosis. Also, it helps with nutritional needs because if they are depressed, they are not eating. Okay, and they have to eat to maintain nourishment. We also give antidiarrheals. There can be a risk of something called wasting syndrome, as the body is not absorbing things nutritionally, and everything just kind of goes right through the patient. So we need to manage that, to manage fluid and electrolyte imbalances and help prevent some infections that can happen if our gut health is not well. And then certainly nutritional supplements are important. And we're going to talk a little bit more about that in a few slides. So as stated before, prophylactic antibiotic therapy will help us to mitigate the risk for infection. And patients with HIV are at most risk for something that we call opportunistic infections. And these are infections that are picked up and they're kind of odd things, especially when we get down here with below the herpes zoster and start to look at TB, PCP, which is a type of pneumonia that they can get, or pneumonia they can get in their lungs. If we go down here and we look at cryptosporidosis, we have something called mycos fungoides that they can get. And these are all very strange things that grow in the body of a patient that is immunocompromised. In addition to things like, they might pick up a toxoplasmosis where most of us wouldn't have problems with it. This could come into some sort of a pneumonia or something like that. But as the CD4 count decreases, the risk of developing these infections increase. Okay. So the CD4 count of above 500, they may be asymptomatic, but as it decreases, it increases their risk for respiratory illness and dermatological or skin manifestations. Okay, so we see things like herpes zoster, oral candidias, so thrush. As that CD4 count increases, the risk for these decrease. Okay, as it decreases even more, they're at risk for severe bacterial infections, and that's what we have at the bottom of this chart. is different types of bacterial infections in the form of toxoplasmosis or meningitis. Those are bacterial infections that can be deadly to a patient. So as their CD4 count decreases, you may see a provider add some medications from a prophylactic standpoint to help patients fight that. If a person has an opportunistic infection, as we go down to the 200 and we see pneumocystis carinii pneumoniae or PCP pneumoniae, typically when we start to see multiple infections such as that, they are considered to have end-stage disease and considered to have AIDS. The other thing that we can do to help mitigate the risk of infection is not only hand washing, but immunizations. Immunizations are important in our patients because they can prevent infections. So we may have to modify their schedule a little bit, and if they are in a time of immunocompromise, we may have to hold on live vaccines until the time where the CD4 count is at a safe range and the viral load is low. But these patients should receive the vaccinations they are able to receive, but they may be on a different schedule when we look at live vaccines. It's also important to talk to family members about the importance of vaccination as well, so that they can protect their loved ones. Remember the neutropenic precautions? Immunizations of family members can be a part of that, mitigating the risk for infection. Our patients with HIV can also experience an impairment in nutrition. The digestive tract is often an early target of HIV. The virus typically damages the immune system and the epithelial cells in the gut lining, and it leads to inflammation and a leaky gut, right? And then our body doesn't have any way to fight that, and it results in decreased nutritional absorption. So a patient with HIV could have a B12 deficiency due to the fact that their digestive tract has been attacked by this virus. These patients, in addition to that, can also experience diarrhea, rapid muscle loss, and weight loss. And so we need to be thinking about what can we do to help, because we know if nutrition is impaired, we have risk of fluid volume deficit, electrolyte imbalances. So we really need to address this with our patients. So things we can do is help with nutritional supplements. We can use appetite stimulants such as Megase. There's also some studies about using CBD or medical marijuana to help stimulate appetite. It is not FDA approved, but there are some off-label studies showing some good help in that with the medical marijuana and CBD. Prescription-wise, we can use Megase as an appetite stimulant to help make them hungry. Antidiarrheals, and then if need be, we can use supplements like TPN or albumin infusion to help correct that nutritional impairment. The next thing that our clients get at risk for with HIV are skin integrity problems. Fighting off infections and virus becomes difficult due to immune compromise. And if we remember, our skin is our biggest type of protection from invaders like bacteria. And so when things are impaired, we can see blisters such as cold sores or herpes simplex, right? And the skin integrity can also be further impaired by nutritional deficits. If our skin in our already immunocompromised patients becomes impaired, it could be an issue that leads to further infections. So what can we do to promote skin integrity health for our patients with HIV? It's going to be important to turn them. Look at your patient on the previous slide. They're at risk for skin impairment with all those bony prominences. So making sure that they're turning and making sure they're ambulated is going to be important. Good oral care or good mouth care is going to be important. We may have some sort of antifungal mouthwash that we help with our interventions, and a thorough skin assessment is going to be important for our patients, as well as meticulous perinatal care after toileting. You can see that this is a complex thing to balance. Our risk for infection, nutritional impairment, skin integrity, they all kind of build on one another. If our nutritional things are not taken care of, or we're experiencing diarrhea, we may also have a risk for impaired skin integrity. And so we have to be meticulous in our care in making sure that we're aware of these problems and addressing them in our patients. So where does HIV become transmission? The last problem that we need to think about as far as risk with our patients is making sure that we are mitigating our risk for transmitting HIV to other people. We know that HIV is transmitted through body fluids and blood, and we have these different situations in which we can pass HIV. So a mom can pass HIV to baby, right? And so how we mitigate that is we begin prenatal antiretroviral therapy at about 14 weeks. We ask mom to bottle feed baby or use donor breast milk, and we schedule mom for a C-section. By doing those things, we can decrease something called vertical transmission, and that's the process by which mom passes the virus on to baby, to less than 1%, okay? But we have to be able to screen mom and make sure that we're identifying the HIV exposure in order to do that. We also know that there's a risk of transmitting HIV to others through needles. And so many times you will see needle exchange programs in play to help mitigate that risk of needle sharing. We know that HIV can also be transmitted through intercourse. And so talking to our patients about using protection or something called pre-exposure prophylaxis. There are medications for HIV positive people to reduce the risk of transmission to their non-HIV partners. There's a medication on the market called Truvada. There may be others on the market. That's just the one that I'm familiar with. And this is used to decrease the viral load to undetectable levels, preventing the spread of infection. But it must be taken faithfully, and there is a screening process that a patient will need to have to make sure that medication is still effective. It also has to be utilized in a monogamous relationship. And so there's a very strict process that the FDA and the healthcare providers follow for this pre-exposure prophylaxis for patients. We also know that we can have a risk for HIV transmission to others in healthcare workers. And what we do in this situation to mitigate this risk is we use standard precautions in healthcare. We use standard precautions in healthcare to determine we wear gloves if we're concerned about exposure to HIV when we're coming in contact with blood or body fluids. So that helps mitigate that transmission to ourselves. Knowing that we're in healthcare, what is it that we should do in healthcare if we are exposed? We have something called post-exposure prophylaxis that we use in healthcare to help mitigate that transmission. And the first thing we need to do is wash the area. Then we need to report the exposure, seek care for that, and then complete follow-up screenings. So we want to hand wash the area with soap and water. Then when you're reporting your exposure, you want to let your charge nurse know so that they can follow the institution's policy on what to do next. Usually that is where they get employee health involved, and then you'll do some testing and maybe some medication. You might take some medication to help with the prevention of transmission. And then there will probably be a series of screenings that you will do, series of rapid tests that you would do at 3, 6, and 12 months to determine if transmission has occurred. So the last thing that we're going to do, and you're going to do in class today when you arrive, is you're going to do an in-class activity.